So for today's lecture, we're going to continue along the same path, and we're going to look at coronary artery calcium measurement. So if the patient falls in the borderline and intermediate risk group, then coronary artery calcium measurement can be done. And if the coronary artery calcium score is greater than 100 Agassiz unit, then you can reclassify the patient risk as upward. So someone comes in and you put them in the pool cohort equation, and they comes out, the percentage is going to be between 5 to 7.5%, and between 7.5 to less than 20%. So the borderline and the intermediate risk predicted group. So if the patient falls in that, percentage grouping, borderline and intermediate, you can do the coronary artery calcium measurement. And if it's 0, then you reclassify them downwards. So they wouldn't need therapy with statins if the coronary artery calcium score is 0. But if it's greater than or equal to 100, then you reclassify them upwards, and you should start therapy. That is statin therapy. And similarly, the decision about aspirin. The current thing on aspirin is you do not give aspirin for primary prevention unless the patient is high risk and they have a low risk of bleeding. And we'll look into that a little bit more as we progress. All right. So the MESA trial, which is the multi-ethnic study of atherosclerosis, what they looked at, they look at ethnicity, and they said that coronary artery calcium score is strongly associated with a 10-year risk of atherosclerotic cardiovascular disease. And they show that if the coronary artery calcium score is 0, it lower an individual risk of atherosclerotic cardiovascular events and death, and there is no benefit from giving statin therapy. So if you're in that borderline to intermediate risk group, and your calcium coronary artery calcium score is 0, you don't need any statin therapy. All right, so let's look at lifestyle factors affecting cardiovascular disease. So, nutrition and diet, class of recommendation is 1. So a diet emphasizing intake of vegetables, fruits, legumes, nuts, whole grain, and fish is recommended to decrease atherosclerotic cardiovascular disease risk factors. So, the diet is a class 1. And again, the diet that we're pushing is the Mediterranean and the DASH diet. So class 2A recommendation, replacement of saturated fat with dietary monounsaturated and polyunsaturated fats can be beneficial to reduce atherosclerotic cardiovascular disease risk. So that's class 2A, replacing the saturated fats with mono and polyunsaturated. Also, class 2A, a diet contain reduced amounts of cholesterol and sodium can be beneficial as well, class 2A. And then 2A, again, as a part of a healthy diet, it is reasonable to minimize the intake of processed meats, refined carbohydrates, and sweetened beverage to reduce atherosclerotic cardiovascular disease risk. So refined carbohydrates and sweetened beverage and processed meat, especially red meat. Okay. Now, class 3, which can cause harm, the intake of trans fat should be avoided to reduce atherosclerotic cardiovascular disease. Okay. Now, when we talk about diet, as we always push the Mediterranean diet. So plant-based and the Mediterranean diet are associated with lower risk of all-cause mortality, and that diet includes a lot of fruits, nuts, vegetables, legumes, lean fat vegetables, or animal protein, preferably fish. The PREDIMED study, or PREDIMED trial, which is the Prevention on Diet Mediterranean, looked at this diet, and what they found was the Mediterranean diet supplemented with either extra virgin olive oil or nuts caused a 30 to 28% reduction in myocardial infarction, that is heart attack and stroke, and cardiovascular mortality, respectively. So you get close to a third reduction in MI, stroke, and cardiovascular mortality by adhering to the Mediterranean diet, supplemented with extra virgin olive oil. So again, the Mediterranean diet is beneficial, and the post-hoc evaluation show that for pro-vegetarian food pattern, which contains more vegetable compared to animal protein, there's a significant mortality rate reduction, 41%. So if you do more vegetables to get your protein as opposed to animal protein, there's a significant reduction in mortality. There's also the Adventist Health Study 2 cohort, and what they showed was that using meat for protein was associated with a 61% increase in mortality, and replacing meat with nuts and seed was associated with a 40% reduction in mortality. So a more vegetarian-based diet was beneficial in the Adventist study. And then when we talk about the DASH diet, the DASH is an acronym, the dietary approach to stop hypertension. Again, low fat dairy products. We talk about reducing sodium, increase food that contains potassium. So that was, some of the studies that look at the Mediterranean and DASH diet. So for the recommendation for exercise and physical activity, and we mentioned this in the first lecture, if you're going to do moderate intensity exercise, then the cumulated weekly exercise should be about 150 minutes. And if you're going to do high intensity physical activity, then the cumulated weekly exercise should be 75 minutes. So for a class 1 indication, class 1 recommendation, others should be routinely counseled in healthcare visit to optimize physical active lifestyle. So you have to discuss this with your patient each visit. And again, a class 1 recommendation, adults should be encouraged in at least 150 minutes per week of accumulated moderate intensity or 75 minutes per week of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous activity to reduce atherosclerotic cardiovascular disease risk. So encourage a patient to be active. Class of recommendation 2A, for adults who are unable to meet the minimum physical activity recommendation that we just mentioned, 150 of moderate and 75 minutes of vigorous, engaging in some moderate or some vigorous intensity physical activity even if it's less than the recommended amount, can be beneficial. So just encourage them to do something, okay? And it's usually a struggle. You have to, constantly go over it with them. But eventually, you keep on saying it, they will do it. Class of recommendation 2B, decreasing sedentary behavior in adults may be reasonable to reduce atherosclerotic cardiovascular disease risk as well. So again, encourage them to do something. And when we talk about sedentary behavior, the metabolic equivalence for that is about 1 to 1.5 METs, and that includes just sitting, reclining, or lying, or just watching television. And we have a lot of people who just get out of bed and they just sit down, or sit down all day, sedentary behavior. So you want to discourage that. For light intensity activity, the metabolic equivalence for that is about 1.6 to 2.9, and this includes walking slowly, cooking, light housework. And then when we talk about moderate intensity activity, the metabolic equivalence for that is about 3 to 5.9 METs, and that include brisk walking, about 2.4 to 4 miles per hour, or biking, that's also moderate, and when you're biking about 5 to 9 miles per hour, ballroom dancing, active yoga, and recreational swimming. So these are the things that are included on the moderate intensity exercise. And then when you do vigorous intensity exercise, then metabolic equivalence is usually greater than 6 METs, and that includes jogging, running, biking. But biking this time is, you're biking more than 10 miles per hour, singles, tennis, and swimming laps. So this gives you an idea of how much energy one expends in doing the various activity. So you're going to encourage moderate and vigorous intensity activity. For an average American, this pie chart shows the hours spent in the various activity. I mean, we usually sleep about 8.3 hours for the day, average. Light intensity activity about 7.8 hours, and then sedentary 7.7. Then we do moderate and vigorous activity for about 0.2 hours. So we need to increase more of the moderate and vigorous activity, and you can take that away from the sedentary and probably the light physical activity. So again, we need to encourage our patient to do more, even if they cannot get up to the brisk walking and the jogging, encourage them to do something. So for overweight and obese patients, it's a class 1 recommendation. In individuals with overweight and obesity, weight loss is recommended to improve atherosclerotic cardiovascular disease risk profile. So we have to discuss weight loss. Every time our patient comes to see us, we have to discuss weight loss. And again, that's diet and physical activity, and we have to go in depth. You can, if it's a fairly well-educated patient, you can let them just go on the website, get a detailed description of the Mediterranean and DASH diet, or you can just give them a synopsis. Just talk about what the Mediterranean DASH diet says in brief. Some people do have handout. We use the EPIC medical system, and that allows you to print out the Mediterranean and the DASH diet. So you can print it out and you can give it to the patient if you're using the EPIC medical record system. So class 1 recommendation also include counseling and comprehensive lifestyle interventions, including caloric restriction, are recommended for achieving and maintaining weight loss in adults with overweight and stuff. So, I have when patient comes in, I usually have a brief description of what the Mediterranean diet is and the DASH diet, and discuss that with them, and then encourage them to Google the Mediterranean diet and the DASH diet. Uh, you know, Patients who are not as sophisticated, then you might have a brochure, a pamphlet which simplify everything. So remember, it's a team-based approach, and you have to interact with the patient, depend on the patient socioeconomic status, educational level. So you have to take everything into account. Also, class 1 recommendation, calculating the BMI, body mass index, is recommended annually or more frequently to identify adults with overweight and obesity. So, you when the patient comes to see you, each visit, we do the weight. You should have a weight. But the BMI you can do less frequently, but every time the patient comes to see you, you should have a weight, and you should know the ideal weight for that patient. Okay, so, and you can discuss that with them, give them pointers on how to get their weight to the ideal level. Okay. Class 2A recommendation. So it's reasonable to measure the waist circumference to identify those at higher cardiometabolic risk as well. As a class 2A. Now, diabetes is a little bit more involved, and so again, remember, this is primary prevention of cardiovascular, atherosclerotic cardiovascular disease. You're trying to prevent the first event. Okay, this is not for patients who have had a prior event, such as a heart attack or a stroke. So this is primary prevention. You're trying to prevent the first cardiovascular event. So patients with diabetes who comes, and if the hemoglobin A1C is greater than 6.5%, and that's consistent with your type 2 diabetes. Okay, so we're not talking about a type 1 now. So this is a type 2 diabetes. Hemoglobin A1C greater than 6.5%. So it established the diagnosis. You're gonna dietary counseling. That is a class 1. So all diabetic patients should be counseled in diet, and you should also recommend physical activity, that is either moderate or vigorous physical activity. As we mentioned previously, if it's moderate, then accumulated activity should be 150 minutes per week. If it's vigorous, then at least 75 minutes per week. So these are stuff that all diabetics, you're going to recommend this to all diabetics. You also going to aggressively treat other cardiovascular disease risk factors. So the diabetic patient may be smoking, they may have elevated, well, let's leave out cholesterol a little bit, but they may have hypertension as well. So you're going to aggressively treat those. It is recommended that if you have a type 2 diabetic patient, they should be treated with metformin as a first-line pharmacological therapy to reduce cardiovascular risk. It is a 2A indication, but once you establish a diagnosis of type 2 diabetes mellitus, you should try and get metformin on board, because it is shown to reduce cardiovascular disease risk. So again, patient is diabetes established with hemoglobin A1C greater than 6.5%. All patients going to be dietary counseled. All patients going to encourage activity, physical activity. You aggressively treat the other uh, atherosclerotic cardiovascular disease risk, and you should start them on metformin. Okay. So the next level. So if you're going to check your hemoglobin A1C on a routine basis. If the hemoglobin A1C is less than 7%, so the current recommendation is less than 7%, and they're on the lifestyle therapy we mentioned before, and they're on metformin, and if they're doing all those things, so this is good management. Just continue doing that. So hemoglobin A1C less than 7, and they're on metformin, dietary counseling, and physical activity. That is fine. Just continue with that. If the hemoglobin A1C is not less than 7, okay, then what you're going to do, does the patient have cardiovascular uh, other cardiovascular disease risk factors? So if they do have other cardiovascular disease risk factor, they smoke, they have hypertension, that type of thing, then you're going to consider, these are the new medication that we talk about, the SGLT2 inhibitors, or the GLP-1R antagonist to improve glycemic. This is your Jordans, those type of medicines. Okay, so and then if they don't have other cardiovascular disease risk factors, then you just continue management with your diet and your metformin, stuff like that. So let's just recap this, because this is very important um, for you know if you're taking care of diabetic patients or you're going to do exams, then you need to know that. So you establish your diagnosis of diabetes mellitus with the hemoglobin A1C greater than 6.5%. So all patients get dietary counsel and physical activity recommendation. You aggressively treat the other cardiovascular disease risk factors, and then you should put them on metformin. Put them on metformin. Now, then you're going to recheck your hemoglobin A1C. If your hemoglobin A1C is less than 7 and they're doing well, you just continue to do that. If the hemoglobin A1C, even the hemoglobin A1C is less than 7, then if they have other cardiovascular risk factors, then you should start on this uh, SGLT2 and the GLP-1 antagonist. Okay, so this is diabetes in a nutshell. So class 1 recommendation for all adults with type 2 diabetes mellitus, a tailored nutritional plan focusing on a heart healthy dietary pattern is recommended to improve glycemic control. You should try and achieve weight loss if needed and improve other atherosclerotic cardiovascular disease risk factors. Again, class 1 for diabetes, type 2. Adults with type 2 diabetes should perform at least 150 minutes per week of moderate intensity physical activity or 75 minutes of vigorous intensity physical activity to improve glycemic control. Try to achieve weight loss if needed, and this is all this will improve their atherosclerotic cardiovascular disease risk. Type 2A, for adults with type 2 diabetes mellitus, it's reasonable to initiate metformin as first-line therapy along with lifestyle therapy at the time of diagnosis to improve glycemic control. And for people doing an exam, they will ask you this, even though it's a 2A recommendation. They want you to recognize the fact that your diabetic patient should be started on metformin because it's going to reduce atherosclerotic cardiovascular disease risk. So metformin should be, unless of course they are contraindicated, it's contraindicated. 2B for adults with type 2 diabetes mellitus, an additional, so if they have additional atherosclerotic cardiovascular disease risk factors, and if they still require glucose lowering therapy, hemoglobin A1C may be greater than 7%. Initial lifestyle modification, metformin, so they're already doing that, diet, physical activity, and they're on metformin, then it's reasonable to initiate the sodium glucose cotransporter 2, the so-called SGLT2 inhibitor, or the glucagon-like peptide 1 receptor antagonist, that's a GLP-1R, to improve glycemic control and reduce cardiovascular disease risk. So what they're saying is first-line therapy for your diabetic patient is metformin. So comes and you establish the diagnosis of type 2 diabetes mellitus. Patient should be on metformin because that's going to reduce atherosclerotic cardiovascular disease risk. If they still have elevated glucose, that is your hemoglobin A1C is above 7, and they, especially if they do have other risk factors for atherosclerotic cardiovascular disease, then you're going to start them on these. And these are relatively new medicines. So you should have a low tolerance for these medicines because these medications, they actually reduce cardiovascular disease risk. So all right, so this is a fairly busy slide. So patient comes in with a high cholesterol. How are you going to handle them? So, you try to simplify it. Remember, we're sticking, the guidelines suggest that you look at patients age 40 to 75. Okay, so if that patient comes in and their LDL cholesterol, low density lipoprotein cholesterol is greater than or equal to 190 milligram per deciliter, these patients automatically going to need medication. So you don't need to put them in the pool cohort equation. So, you start high intensity statin in these patients. LDL greater than or equal to 190. Okay? If you have a diabetic patient that comes in, age between 40 and 75, if just the fact that they're diabetic, you're going to start them on moderate intensity statin. This is a class 1 indication. So these are class 1 indication. Any patient comes in, the LDL cholesterol greater than or equal to 190, high intensity statin. Your diabetic patient between the age 40 and 75, moderate intensity statin. Okay? So your diabetic patient, of course, we're looking at age between 40 and 75. The recommendations is look at this age group. Risk assessment to consider high intensity statin. So the only reason why you're going to risk assess your diabetic patient because they automatically need moderate intensity statin. You can put them in the pool cohort equation just to see if they should be placed in high intensity statin. Okay? For patients greater than 75, the clinical assessment and risk reduction you have to discuss with the patient. And so don't be gung-ho in your patients above 75, and you have to discuss with them. Okay, so again, remember this is the age group that we're looking at, age 40 to 75. All your diabetic patients should automatically be on moderate intensity statin. If they're high risk now, then high intensity statin, and there are different dose. So for example, if you're going to put someone on high intensity statin, that is equivalent to atorvastatin 80, and then moderate intensity statin is atorvastatin 40, and then Crestor. So only atorvastatin and rosuvastatin can you get high intensity statin. Okay, so you put your patient in the pool cohort equation, and we went over what that looks like. You just Google it. So just keep everything simple. You Google it, and you just put in the information, and it will give you it will calculate a risk for you. And if it's less than 5%, then the patient is low risk. If it's between 5 and less than 7.5%, then the patient is borderline risk. If it's greater than or equal to 7.5 to less than 20%, then they're the intermediate risk. And if it's greater than or equal to 20%, then patients in the high risk. So you have to know the risk category that your patient is in. Okay, because I don't think the calculator, well, it depends. Some calculator will give you the risk, but you need to have an idea. Greater than equal 20% high risk, less than 5% low risk. Then we have the borderline and intermediate. If your patient is low risk, then lifestyle recommendation, diet, exercise. Everybody gets that. If the patient is high risk, greater than equal to 20%, then you should start statin therapy. You should start your statin therapy. And the current recommendation is when you start your statin therapy, your goal is to reduce the LDL cholesterol by 50% or more. Okay, so this is the current guidelines to reduce the LDL cholesterol 50% or more. So it's not less than 70. Okay, now for your patients who are in the borderline and the intermediate risk category, they're a little bit more tricky. So you're going to use your risk enhancers. Remember, we talk about the risk enhancers. So these are the groups that you're going to use the risk enhancers. And when you use the risk enhancers, it can risk them upwards or it can risk them downwards. Okay, this is a little blurry, but we went over this before. These are the risk enhancers, the family history for male less than 55, female less than 65, persistently elevated LDL cholesterol greater than or equal to 160, chronic kidney disease, metabolic syndrome, conditions which are specific to females such as preeclampsia, premature menopause, inflammatory disease such as rheumatoid, psoriasis, HIV positive, the lupus, ethnicity, South Asian ancestry. Then we talk about elevated high sensitivity reactive C-reactive protein greater than or equal to 2, lipoprotein little a greater than 50, and then the APO greater than 130, ankle brachial index less than 9. So again, these risk enhancers can help you to risk the patient upwards or downwards, and this is only in the borderline, the intermediate risk group. So you can just Google this, print it out, and put it up, so you don't have to memorize it. So if your clinical decision is uncertain, that is when you can consider your coronary artery calcium scoring in selected patients. So again, as we said, a coronary artery calcium score of 0 going to risk the patient downward. So consider no statin unless the patient is diabetic. Okay, there's a family history of premature coronary artery disease or cigarette smoking are present. So as a coronary calcium score of 0, you're going to risk the patient downward. Coronary calcium score of 1 to 99 is going to favor that the patient should be on a statin therapy. And if it's greater than 100, then you should initiate statin therapy, definitely. Okay? So a couple of things on cholesterol. So attention to atherosclerotic cardiovascular disease risk factors should be started early in life. So, don't wait until the patient between 40 and 75. You always encourage, healthy diet, physical activity, and condition to reduce cholesterol. The benefit from statin therapy is related to both the global risk and intensity. So remember, the higher the risk, the more benefit. And if higher dose will get the cholesterol down lower, so there will be more benefit. However, but some patients cannot tolerate the statin, so you have to bear that in mind. So patients with diabetes have a higher trajectory of lifetime risk than those who are without diabetes. And that is why once you establish a diagnosis of type 2 diabetes mellitus, they at least warrants moderate intensity statin. If they have additional risk factors and you put them in the pool cohort equation and they are high risk, then high intensity statin. So high intensity statin therapy is preferred in patients with diabetes as they develop uh, risk modifiers. So if they have the risk modifiers that we mentioned before, then probably they should be an high intensity statin. But you can put them in the pool cohort equation. These are some of the risk enhancers in diet in that type 2 diabetes. This is specific for type 2 diabetes. So a long duration of diabetes that greater than or equal to 10 years for type 2, or greater than or equal to 20 years for type 1. If they have albuminuria, greater than 30 micrograms of albumin per milligram of creatinine. If the GFR is less than 60. So those are specific risk enhancers in diabetic. All right. And then, if they have retinopathy, that is a problem with the retina, neuropathy, or if the ankle brachial index is less than 0.9. Okay. So when we go back and we look at the coronary artery calcium score, if the coronary artery calcium score is 0, then you're going to risk the patient downward, as we discussed before. Especially if the patient is reluctant to initiate statin, you should discuss it with them, and they probably shouldn't be treated. If the patient is concerned about reinstituting the statin therapy after discontinuation, if they have a calcium score of 0, then you probably don't need to start a statin. Older patients with a low burden of risk, if they have a calcium score of 0, then probably not. Middle-aged adults, age 40 to 55, with a pool cohort equation calculated 10-year risk of 5 to less than 7.5%. So this is your borderline category. And if they have factors that increase their risk, even though they're in the borderline risk group, if they have a calcium score of 0, you think twice. Okay, so a calcium score of 0 it gives you a lot of information. So, and you'd probably only do your coronary artery calcium score in your borderline or your intermediate risk group. Okay. All right. So let's stop here, and we will discuss a few more preventative measures in our next session. Next session is going to be on Tuesday,